So what we're going to talk about a little bit, of course, is access to care in rural areas. That is a big piece of what we do. So give you a real quick, we are dealing with HIV specialty care. We're a nonprofit organization. This is the 30th anniversary of our organization. We have been doing this then for 30 years, and when they started, they were strictly a program that did respite care and education programming, and they were doing prevention. And basically what they were doing in the Montgomery area were people were coming home to die. And we had a lot of parents, grandparents and stuff who didn't really know what to do. And so as in good Alabama fashion, they were stepping up and taking care of their kin, but they didn't have resources or knowledge base. So that was actually really good for MAO at that time when they began to really fill that need. So what we also moved heavier into is hepatitis C care. That's also a very underserved issue in Alabama. We are moving next into diabetes care. And that's going to be a big push because, as you'll find, we serve mainly southern part of Alabama from Chilton County all the way down to the Georgia-Florida line. We're moving closer to the Mississippi line. We do a series of clinics structured out. We serve 3 particular areas of the state. We serve the river region of the central part of the south central region. We serve the Wiregrass based out of Dothan, and then we're serving in the traditional black belt counties of West Alabama, Southwest Alabama. So our goal certainly is that we'd like to see HIV/AIDS eradicated, but we also are taking a successful model they call the Ryan White Care Act model, and we want to expand that out beyond because it's proven to work, and we'd like to do other morbidities and deal with the issues that are facing in Alabama. So when you look at us, because we're an ASO roots with an AIDS Service Organization roots, we tried to put everything under one roof, one umbrella. A lot of it was because our consumers were very poor. Also, we had consumers that did not want to go out and people know that their HIV status, because it was that much of a fear factor and stigma. So as we see now, we do primary care for our individuals we serve. We have case management services, social work services. We're increasing our behavioral health program with both substance use and mental illness. We are dealing much more Hep C treatments. We have opened up in June a dental clinic out of the Montgomery region. It's been great. We've had people who had dental care when they were kids, have not had it since then, and they're now 35 and 40 years old. So it's amazing what we're seeing, and dental care is a big issue with individuals' compromised immune systems. Telemedicine is a big piece. This is something I want to talk a little bit about today and how we use it, because it may be different from what you may think. And then we do a program called PrEP, which is a pre-exposure program to try to prevent people from picking up HIV. And we do that not only with individuals, like our targets right now are young African-American men who are having sex with men, because unfortunately they're coming in at a much higher rate into our clinics. But we're also have a push to do PrEP for women. Women are also a group that oftentimes does not think about using PrEP, but I think it's real important for women to understand what this pre-exposure program could really mean to protecting their health. We do have patient and provider education. We are part of ATEC, the AIDS Education Training Center, which also UAB is involved with. We all work with Vandy, and we do a lot of the provision of the cares through our capacity building program. Our food bank is a big deal. It brings consumers, keeps them in. Basic stuff that really holds folks on. We do housing and medication assistance because, again, so many of our folks are poor. And then the outreach, we're doing HEP and HIV testing. We're actually moved to do STI treatment and testing now. We've been approved to do that part, so that's going to be a big push. We do prevention education, and we're really working to try to build up a stronger Latino outreach, Latina outreach programming in South Alabama. We have large communities, particularly for people from Central America, people from Guatemala and Honduras and El Salvador, and they're in small areas throughout rural Alabama, oftentimes in invisible communities, both because they want to be because of the concerns in our current environment, but also because it tends to be a very closed community. Everybody's kind of watching, protecting one another. So we're doing increased work to try to reach the communities and get people into care. So we're looking forward, as I mentioned, we're going to do more diabetes care. I really want to get community-specific care. We're about to, some of you may be aware here in Birmingham, BAO has a program. It's the Magic City Wellness Center. Wonderful, wonderful program. Karen Musgrove and her folks have stepped up and just taken it on. We actually gave them some technical assistance in the beginning on just how to get started doing clinics. And they not only did it, they took it and ran with it. It is wonderful. We're going to do similar for specialized care communities. We're going to have a women's wellness clinic out of our Dothan and Montgomery offices to try to deal with a lot of these preventive programs for women, especially poor women, and also LGBTQ issues. We have got to have a better resource because I think that's the way we can reduce a lot of the poor health care outcomes in the state of Alabama. And also building up a good patient advocacy program. So this you may have seen before. So what we have at this point, this is a Washington Post article and is actually done kind of profiling what we were doing in South Alabama. And the statement was the stigma surrounding AIDS, and that was the term that was typically used a lot, although I don't really use it as much with the consumers we serve, is a key reason that the South is the epicenter of new HIV infections in the United States. Now this article was done about 5 to 6 years back, but it's still holding true. Half of all new infections in the United States are in the South. And the South has the population, when you look at it, it's about 33–34% of the United States. But yet half of all new HIV infections are in traditional Deep South states. And that is prompted, you can see here a little bit, by the dark colors. And those colors are counties with high rates of HIV infection. So expanding that out, you look across the U.S. Look, the darker the color, the higher the rate for HIV care. I'm sorry, I'm blocking some of your view here. So if you're looking at that, see these areas in the South, Mississippi, Northwest Florida, Alabama, South Carolina, Louisiana, a lot of those are rural counties, which means they may have fewer population, but because their rates are so high, the likelihood of meeting someone with HIV can be even stronger in those rural areas. So what you have is HIV in the South has become very rural. It is very much African American right now. We've always had more women living with HIV than the rest of the United States, and especially in our area we cover, because we're about 40% of our consumer population are women, and most of our brand new patients coming in are women right now. And so what you see is this southernization of HIV. And this has been an issue for us as we looked at how to get the money to come south rather than to stay in traditional areas like Miami, although Miami is a southern city, it's more of an international city, New York, California cities like San Francisco, LA, et cetera. The money in the beginning did not follow the trend of the HIV. So we were already in poor states that don't fund very well on taking care of our own people. And then we were battling the issues of poor health care and poor issues coming in with going on. So if you look at it, let's look at Alabama, for example. We're approaching 5 million people. So the area that's sort of mustardy looking there, that's going to be individuals who are identifying as Caucasian or white. The next largest is sort of the bluish tint, and those individuals who are identifying as black or African American. And then you have breakdowns, the Hispanic, Latino communities are more in that. Is that salmon? I am not really good on color coordinating on that one. So this is where you break down. Now keep this in your mind, and I want to show you that. So if you looked at, in 2015, the demographics for HIV, remember the other? Well, in this case, the salmon color are those individuals identifying as black or African American in Alabama, and those are the individuals who are living with HIV and the AIDS diagnosis. So what you have is a mirror flip. It is disproportionately larger. And then the Caucasian, white communities, you see about, again, the flip on the other side. And then we do see Latino, Hispanic. We're trying to do a better job. We're concerned about those communities if even, or testing is going on as well in the Latino communities. So 65% of newly diagnosed HIV cases in 2015 were among African American or individuals who identified as black. 70% of all persons living with HIV right now in Alabama are African American or identify as black. So let's break it down a little bit further. So the prevalence, we had probably in 2014, they were indicating about 12,439 people known to be living with HIV in Alabama. We don't know because not everybody's been tested. It could be more than that. We had a rate of people living with the diagnosis about in 2014 per 100,000, about 306. 72% of the people living with diagnosed HIV in 2014 were male, 28% were women. They do not break that down on transgender individuals at this point, so we're not sure how that may translate out a little bit. 64% of the people living with the diagnosed HIV in 2013 identified as Black or African American, 3% Hispanic, Latino, and 28% Caucasian white. Now the new diagnoses we're looking at in Alabama, we're about number 12 out of the 50 states, and not pulling in Puerto Rico in that group. And the number of deaths with people diagnosed in HIV or 2014 were 284. Now, I want you to pay attention on this number. That rates of death among people diagnosed, Alabama's ranked number 7. So it means if you're living with HIV, you still have a better chance of dying with it if you live in Alabama. And there's some reasons behind that. But that's a big issue. What we noticed was, I went through, in DC there was a group that were doing the statistical reviews, and what they found were the state that was ranked number 1 if you were Caucasian male living with HIV, your mortality, you would probably die quicker, was Alabama. Number 2, if you were African American male, Alabama was ranked number 2 for mortality, so you're likely to die. So that's not saying a lot for us right now in Alabama, even though I think we're doing pretty good. We're not reaching people until they come in sick, and that's a problem. And this is just another real peek on the trends. If you notice a little blip here, it dropped down, and you think, oh, that's looking good, but what happened to some of the numbers? What happened was they cleaned up data. The Surveillance Division, the ADPH, at the Alabama Department of Public Health, and they wound up, like duplicates, they pulled out. So you all of a sudden, that's a much cleaner data pool, and they're doing a great job right now of making sure not duplication on that. What bothers me a little bit here, we still have 45% of the people who are living with HIV/AIDS in Alabama are at that AIDS diagnosis. We shouldn't have that. That should be much lower. Because if we get them in treatment early, then they never progress to that. I can honestly say that. So we've got to do a better job on that. And that's part of it's going to be early testing initiatives that we got to get into. But I want to go into real quick, and I think this is something you all, particularly in public health, will appreciate. I want to give you a feel for why it's not just HIV. So I want you to look at this. These are heart disease death rates, and that was just pulling from 2011 to 2013. So look at the heart disease problem areas. Darker the color, the higher the rate. Looks familiar. It's back in the South particularly, including the Midwest. We appreciate our Midwest cousins because apparently they're just as unhealthy as we are. Then you have the pockets out on the West Coast. But you see that big issue in the South. Look at particularly at Mississippi, Alabama, Louisiana, Arkansas, dark counties. So that is death rates for heart disease. Again, mortality. Then let's look at cardiovascular disease just in Alabama. So I want to show you this part. So if you remember, I may have to jump back real quick. So look at this particular area. These counties here, the darker the county, the higher the rate of HIV. So you have Jefferson County has the most cases of HIV, and they actually are ranked in the top 12 as far as rate of infection. But the county that actually has the highest rate is Montgomery County. And then look at the counties beside it are Lowndes, Macon, Dallas County. Those are small communities, and yet their rate of HIV infection are high. And then South Alabama, if you notice the big difference, more mountain communities of the very north are much lighter in the rates of infection. Further south you go, the higher the rates. Now, there are reasons, of course, for that, and that's part of what we're going into. So if you look, cardiovascular disease, mortality rates. Some of those same counties, particularly in the west, that had high rates of HIV infections, you notice their mortality rate for cardiovascular disease also very much out of proportion. You go further, heart disease mortality rates, surprise, same counties, we got problems still in those same areas. And then out in the southern parts, you see those high rates pocketed out. Stroke. Again, there's a belt in the black belt communities of Alabama. And you see those same counties, the stroke mortality rates, extremely high, little pockets throughout the other parts of the state, but a heavy impact in southern Alabama. High blood pressure in Alabama, again, 47%, the black belt, traditional black belt, and then the wiregrass. And then you have pocket up there in the northeast corner too. Cholesterol rates, you see the pattern? See what I keep showing you? It's just building on itself. It really comes down to we are just continuing to see the same areas that these high rates of HIV, you're seeing these issues going on. And it just keeps getting more and more of an issue when you get into diabetes care, which is one of the areas that we've got to address in my area. I've got to reach out into the areas around me. And that's why we're going heavier into diabetes care using our model to try to get into these counties to better serve the individuals there, because it's all building on itself. I want to throw this last one in just as an overall view. This is the Deep South. The Deep South has the highest teen birth rates in the nation. Now, I'm going to say this. I was born and raised in Alabama, in rural part of Autauga County, in the very central part of the state. I am the son of a Baptist preacher who worked 3 jobs. And my mom worked inside the home and outside the home. I was raised very country. I had grandparents that helped raise me, and I appreciate them greatly. And I'll get emotional when I talk about them, because they had nothing. We came from poverty, but we didn't know it because we raised our own food and we were able to survive. But just to note that. And that's also a quick side note. Why I dress up is in honor of my grandmother Murphree, because my grandmother Murphree said, when you go to town, you got to dress and look clean. So she said, they already look down upon you because you're farm people and you're country folk. So you're going to go to town, you're going to be clean. And I do this in honor of my grandmother Murphree to make sure. So teen pregnancy rates, why I mentioned all that is we pride ourselves in Alabama on being, really the piece of the Bible Belt. We are a very churched and synagogue-related community in Alabama and in the South. But we got issues when our teen pregnancy rates are high like we have them. Somewhere there's a mix. It's just like we talk about the fact that folks are going down to the church on that Sunday, but they've been down in New Orleans now on that Saturday. And yeah, but they're in church on Sunday, that's good. But we still got to talk about some issues. Teen pregnancy is one of those issues that we're not addressing very well in Alabama. I'm going to tell you another piece. When you look at the highest teen birth rates in the nation, Alabama's ranked number 9. Look at number 1, Mississippi. And then got Arkansas, Texas, Oklahoma, Louisiana, Kentucky, heavily southern. We got issues, and these are areas that so pride ourselves on so many of these moral issues, but yet there's a breakdown going on. And it's not translating when we talk about public health issues. Why I bring up teen pregnancy, it is a public health issue, mainly because many of these are young women who are getting pregnant, and as this shows it breakdown on the age group, their bodies really aren't ready for it. They're putting their bodies through so much. They're also more susceptible to STIs, and we know that because physicians have shown it time and time again. So if you go to a county STD clinic, you're going to see a lot of teenage girls in there. And it's because of these issues that we're running into health concerns that keep going for the rest of their life. And this is breaking down along ethnicity rates. So why is all this? So let me present my view on why this is occurring and what we're going to address, how we're doing it with MAO. So I look at 4 big issues that I think Alabama, but I could almost say Mississippi's dealing with this if you're from Mississippi, because your state health department has had major cuts. The state legislature in Mississippi sliced your budget like massively. So you're even worse off than Alabama, and that's not saying a lot. But We got 4 areas that I see for especially rural. And again, you're looking at those black belt communities and others. 1, poverty. Alabama's just poor. We are poor to the point that it's impacting people just getting into care. And even when they're there, will they have access to that care? Transportation in rural areas is almost non-existent. You occasionally have those little bus systems that can run. They're not consistent. Ladies and gentlemen are doing great trying to keep it running, but they're very limited on what they're able to do. So if you're in a rural area, and especially as you get older, if you don't have a car and can't afford one, then you're going to pay a lot of money just to get into the city to get care. Stigma for HIV is still very relevant. My folks that I deal with, my consumers, still to this point in rural Alabama, do not want people knowing their HIV status. They will admit, it's just to a point that it's almost paralyzing to them. And I think it's better, but I'm not living with HIV, so I can't say that. And I can encourage them to speak out, because once they do, they just do better, but I can't force them to do that. In other parts, here in Birmingham even, there's more vocal community of people living with HIV who will stand up. But in other parts of the country, they're so far ahead, and their health care gets better when they do speak up, because then they go to a congressman or congresswoman in a legislature and say that they're a person living with HIV and they're in their district, and they need help. They need support on these programs that are working. And then lastly, health professional shortages. So let's talk poverty. Again, darker the color, in this case, the higher the poverty levels in the state. Same areas, we had all those poor healthcare outcomes. Poverty breeds that peace. And it is because there are fewer financial resources for the individuals in those communities, and businesses are gone because they're going to places where they can have a more educated population and have a place to be able to put industry in. So they're not coming to Southwest Alabama, particularly areas above Mobile. And then down in our area, we're a little bit better off in the Wiregrass, but we're still having issues, especially in that gap between Dothan and Montgomery. You see the poverty rates in that area, massive. Primary care health shortages. Now this is something, if you're in your public health and you're getting your master's, this is going to be an issue that we need your brain power on. And I'm going to say here in Alabama particularly, which is why I'm trying to keep you from leaving the state, but I need that also in the states around us. On this particular map, the counties that are in the white are the areas that they have enough medical providers. That includes MDs, nurse practitioners, PAs, to adequately serve that population, because they break it down on ability to be able to reach those individuals that they would have access. If you're looking at that, you technically have only 5 in the state of Alabama where there are enough medical providers that would adequately be able to address the healthcare issues of the people just in that county. If you're in those lighter blues, that's partially covered, which means those areas have providers, but it really is not enough to be able to serve that population base. And then if you're looking at the dark, those are the areas that have none, that the providers have left, or they died off. We've had issues where elder providers came back in just to try to take care of the people in their county because no one else would come in. And they're 74, 75 years old, and they're concerned, but they're following their oath to make sure they're taking care of their people. But what's going to happen when they die? No one's going in there to take care of them. And make it worse, Alabama's Medicaid situation is so dire that hospitals are closing. The hospital in Camden is about to close. The hospital in Clark is projected to close. Every time you lose a community hospital in a rural area, that's healthcare completely gone, because more often than not, that's the only physician or medical provider that you've had in that area. And when they go, then those folks are going to get sicker, because then they're going to have to go even further to try to find a doctor. And I'm just going to tell you what country folks will do. They'll just not go. And if you've come from a rural area, if you've got grandparents from a rural area, you know what I'm saying, because they will tell you they don't want to go to the doctor. They'll give you a story about Miss Johnson from the church who didn't go to a doctor for 35 years. And all of a sudden she went to that doctor and they put her in the hospital and she died the next week. Well, that's because Miss Johnson didn't go to the doctor for 35 years. But you better not tell your grandmother that, because she'll pop you in the head with your shoe. But still, the reality is that is what's happening. Rural people don't go. They'll just say, just tie up, their arm could be falling off. Now they just tie up with some duct tape, and I'll spray WD-40 on it. Now, you know, WD-40 kind of takes care of everything among country people. But what we're seeing is that mentality. If the more barriers are up there, they're just not going to go, and they're going to get weaker and sicker in their health care issues. And I want to plant this seed for you. Why this to me is kind of important is because right now we in America are addressing health care issues, and we're saying what's really needed and what people should have access to insurance or not, etc. So I want to tell you why that's important. It's important now, but it's more important for you all as you get more into your life and career and your families, that one day you may have to tell your grandkids that the decisions made right now made their lack of health care even more impactful. So what this was an 1860s census that showed where individuals were that were identified as slaves and those that were identified as non-slaves. If you look at that one, the dark color, the reddish color rather, are those that were white or those who were not slaves. If you look at the blue color, those were the counties that were heavily populated with individuals who were identified as slaves. Now, do you remember all those I showed you? Does it surprise you that those areas are still in southwest Alabama? Those were plantation cultures. Why, and I'm going to plant this with you, what happened then still impacts us in our health care issues right now in Alabama. And why, the reason for it is, what you had in those times, those counties, there were massive financial differences going on. You had the individuals that had the land who owned slaves, very wealthy. You had those, of course, who were slaves, did not have any money or had very little money. So you had no middle class in that area, so you had the extremes. And what occurred is after, as I've said before, in many cases, slavery is a doomed mindset anyway. It was doomed as a financial because you don't breed a middle class. Only a few get a lot of the money. It was a moral failure, as we all know, for a lot of reasons. But all of that pulled in. What occurred there after the plantation cultures disappeared, rich people who still had money left, those who lost all their money, they just kind of eased out. What you were left with was a very poor population that had very little connection to true health care before slavery was abolished, and then they had few after slavery was abolished. Does that make sense? And so what you occur then is that model retained in Alabama to where we are now, where you still in 2017 have very few access to true medical care in that area. And I believe it still haunts us at this point, and it is something that we've got to address as a state and as a people. So let me tell you our model, what we used to do. This is some of my staff members, what we did for many years, and I was hired as a part-time social worker to come in to work with an expanding clinic concept. And did not know anything about HIV, didn't think I needed to know anything about HIV, but it was going to be great because I was going to learn some information. I was going to get another master's degree. And I got hooked because the consumers coming in, such good people. And I realized they were living in isolation and they needed help. So it hooked me. So in the beginning, we would take a van. Now this was our nicer van. When I first started, we were riding in a car, me and a doctor and a front desk person and a nurse. And there were so many stories I could tell about those travels around rural Alabama, but I've sworn to secrecy on that, so I cannot do that. But then later we got the van, and we would take a full van out to rural areas and do clinics. We do them in a health department, we do them in a federally qualified health center, we do it wherever we could do. And it actually helped a lot. We were able to get rural care to broaden. They weren't having to come. Like I at one point had clients that had been coming from Dothan, Alabama to Birmingham to 1917 clinic, and one way and one day, that's a massive amount of time just to at that point be a limited amount of meds that they were to get and then come home. So they were exhausted. So to be able to put that in really helped a lot to be able to start expanding care. And this is where we go. We're traveling down the roads of rural Alabama. This is actually a beautiful road between Montgomery and Selma. This was where we wound up putting our first telemedicine clinic. And for those of you in the aware, that's the Edmund Pettus Bridge, the site of really a major life-turning moment for this country. But it was also an area that we definitely needed to go into, unfortunately because of the HIV rates in Dallas County and the surrounding counties. And so how we've adapted, we developed what's called the Alabama eHealth Network. And what that network runs is we come in and we've established satellites throughout. Right now, our hub sites are in Montgomery County, down in Dothan in Houston County, and we've just opened up, in Escambia County. We're in Atmore. And our goal is to have a hub of staff that can serve that entire region, but we're linked by telemedicine equipment. And I'm going to tell you how we use it is different. For some, they use telemed equipment as a Skype model. So what you have is a physician on one end and a physician or nurse practitioner on the other, and they consult more. Well, we actually do direct care with it because in many of our areas there are no physicians. So what we do is we base our registered nurse. We can use an LPN, but we use RNs. They're out in the outlying satellites, which are shown by the little TV screens. And they beam back to my physician or nurse practitioner at one of the hubs. And how that they work is they have a full-on setup. So the physician in this case, and that's one of my staff members doing the modeling for as a consumer, the consumer could be 200 miles away. And then we can link in, the doc's got the computer in front, but they have Bluetooth stethoscope, which you can see barely on the side of that computer, Bluetooth stethoscope. So the Bluetooth stethoscope is mated to another stethoscope on the other end, again, 200 miles away, could be 2,000 miles away, wouldn't matter. And what they do is they have that unit connected up. So the nurse is doing the full exam, the doctor or nurse practitioner is guiding along. And it is registering back, and the physician is hearing everything that's going on at that other site. Their heart rate, everything, just as if they're there. To a point that my doctors actually like the Bluetooth stethoscopes better because they can amplify it so they can hear better even when they're on site patients. But they're beaming that back and forth. And they also do otoscopes. They can do ear, nose, throat review. Everything is then captured in the electronic medical record, and then the physician is guiding everything along the way. Now, it is so precise that we were doing a little thing here, and we had one of the nurses here at UAB, and they were doing a little model concept back in Montgomery to UAB and showing the connection. So our doctor said, could you do this so-and-so, and the nurse started moving it across herself. And all of a sudden the doctor said, oh, hey, hold on, could you go back? And she said, no, I know, I've got an arrhythmia. It picked up just moving across her body. That's how precise it is. And I say that because what we looked at when we started that transportation, that van, was we were traveling 2.5 hours one way, 2.5 hours back. So that we were having very limited time actually seeing patients at that other end, and we had to rush them through. So right now what we're able to do is we have consumers that could go to any of those satellites and they can be seen. If they miss the appointment, we can still work them in better because the nurses can run by there and still see them. So retention has increased dramatically. And that is the key. We give people multiple options. They can opt not to do telemed and we'll see them. It's just we can't be down there as frequently and they would have to travel up. But what we can do is offer options, and our consumers who are using this are fascinating at how much they're using. So right now, we're doing telemed services, we do medical care, we're doing individual psychotherapy and addictions counseling now using Our social workers are using it more, so even in our most rural outlying areas, they're able to be getting this kind of social work services. We have pharmacology. We are doing a pharmacy program. UAB, Auburn at Auburn works with us because they're pharmacy school, but we're also having in-house pharmacy now. We are seeing individual nutrition therapy we're using, and then we do a lot of consultations we can link people in. And out of that, we have seen a huge amount of buy-in from our consumers. Now, some of the things that you may run into, is you have to get a lot of buy-in from your collaborating partners, because we're at public health departments, and we have our UAB site in Selma. We're at programs with federal clinics. But once you get them involved with you, then they buy into it and they see the benefit. It works really well. You got to get state and local leaders buying into it, and we've actually made a lot of headway with that, because Alabama now is looking at that as a way to better serve our people. So let me make a note to you. Depending on where you go to practice later and where you go to serve, this model could work anywhere in the U.S. It can work anywhere in the world. And so this, for rural countries and rural people, this is a way to be able to do it. Because Alabama, we had to find matching funds. We're a nonprofit in a poor state. That was a barrier for us, but we figured out how to do it. Your third-party payments are actually better now. Blue Cross Blue Shield does parity. It will pay telemed services at an equal concept as it would face-to-face. You certainly got to get a good web-based electronic medical record system, which you will learn very quickly. No one likes their medical record system. Everywhere you go, your doctors there are going to say how much they hate it, but that's just going to be the way it is. We got to have them. You got stigma, of course, that we're dealing with, and just technological issues if you're a small organization. So we right now have about a quarter of our patients are using telemed. We serve about 2,500 people at this point through all of our services. So 1/4 of those now are telemed only. Every patient has a right to see a provider in person. Most of the patients really like the technology. We were concerned how they might react to it, but they actually found it very, very easy to work with. And as I mentioned to you about the rural scenario, country folks dress up, I've had more than one time where a consumer tells me that that's their American Idol moment, that when they come, they dress up because they know they're going to be on camera. So that's a good thing. And they come. It makes it worth doing it because they really are buying into it. We also are seeing, we had concerns about would the patient be concerned about the information being just blasted into the web and people hacking in. But what we tell them is we actually encrypt our system stronger than the Department of Defense does. And it's true. We're actually at a higher encryption system than the Department of Defense does. And we actually have done really, really well about protecting. We've not had any concerns with our HIPAA reviews. 90%, over 90% reported being extremely satisfied with this service, and none reported being dissatisfied. Over 95% have virological suppression. Now, let me tell you what that means. Virological suppression means it drops to a level below a certain point to where, in essence, that individual is going to live long and healthy. HIV is not going to be the thing that really takes their life. And we are at that point now. Part of the reason we changed our name and moved away from the word AIDS is our folks are not moving to the AIDS diagnosis, and I don't think they ever will. We have gotten to a point that this virus can be controlled. Still not eradicated yet, but controlled. Now, it doesn't mean people still can't get it, but we can make the life and quality of life so much better than they could even 6 years back. But let me tell you the other part why that virological suppression rate is important. If you get that virus below a certain level, all data now shows that that person cannot transmit the virus to someone else. Now think about that. We use that then as treatment as prevention. And that means if I can get every one of my consumers below detectable level, exponentially they're not going to go out and we're not going to see an increase in HIV in the state of Alabama. That's a major importance. We suspected this even 7 to 10 years back, but we didn't have the data, and now we see the data, and it's proven to be true. And then 94% retention rate. We're actually on the next run, we think it'll be 100%. Those patients who start with telemed stay with it better. They actually do better than our face-to-face patients do. And I think they're buying into the technology. They think they're getting an even higher level of care. They're really getting the same care, but all those bells and whistles and everything, they're getting like Star Wars technology, and they love that, and that's really important. So let me tell you a last piece before I finish it out. On the horizon, and what I think is going to help us even more when we use technology for care. I do believe at some point that we are going to see holographic imagery in doing care. And I really believe that because they're actually in some places using that for training now. I believe that's going to happen. We're looking forward to the tactile glove. Tactile glove is going to add another dimension. So that would mean the physician or nurse practitioner has tactile glove and or gloves on her hands. Nurse has it on his or her hand on the other end. They can feel bumps, lesions, things. It transmits to the glove that the physician is wearing, and they're feeling the same thing. That's just so awesome to me. I know that's a techie, geeky thing, but I just think that's fascinating. And if that being the case, then the physician is going to have one more piece to be able to make diagnoses and treat. So that's coming, and that's around the bend. And this technology keeps getting stronger and stronger to a point that we at MAO have now started a telehealth resource center. We're actually training others on how to do direct practice medical care using telehealth. And we're not only doing it in Alabama, we've got people coming here, but also South Carolina, North Carolina, and we have a potential contract with a group in New York City linking Bronx and some of the other boroughs there. And you know, is there not some satisfaction that they needed to come to rural Alabama to get technology training on, on specialized care that they're going to take back to New York City? That's kind of good. I like that from my perspective. That's really kind of neat. Our comments, just a few. I like seeing my doctor through the TV. One of the consumers says it's not really different because it's the same person. Dr. Batt was wonderful. He has since moved to California because his wife is in residency program there, and she said, you got to come out here. We can't have this distance anymore. So he's moved out to Cali and practicing there. But they used to say they see him in person and on TV. It's just the same. And these were just some of the info from the very first. We're waiting right now on our next level, so we're excited on what that data could show from the evaluations. We thank AIDS United. They helped us to get the collaboration grants. The Alabama Department of Public Health, Centers for Disease Control also supported us. UAB Family Residency has been great to us. Rural health federal centers and health services throughout the area. And we do that in Alabama because we are a poor state. What we learned to do very early on is collaborate well. And that is how we salvage our systems, even in a resource poor state. And we are making headway, and we're really happy about that.